Next speaker, please, Joanna. Yes, lovely, thank you. I'm sorry, I'm going to keep pushing you, otherwise people will be losing their brain. I don't think you're popular.
That's fine. I'm Joanna Seller, I'm a clinical psychologist, and I've been using interpersonal psychotherapy for about 7 years. I'm presenting in places at Roslyn Law, the module lead for IPT-A. IPT was originally developed as a treatment for adults with depression in the United States and was adapted for use with adolescents, IPT-A, by Laura Muffson and colleagues in the early 90s. And it was included in the NICE guidelines for depression in children and young people in 2005. It focuses on what's important to young people, their relationships, and I think that's its greatest strength. It meets young people where they're at. For example, the focus can be conflict in relationships with parents, or the loss of love relationships or friendships, and all of these are common elements in the adolescent phase of development. They can trigger and maintain depression, and importantly, they're often the areas that adolescents want to talk and think about. So its treatment objectives, it aims to reduce interpersonal difficulties and improve depressive symptoms through psychoeducation, understanding emotions in interpersonal context, developing skills in identifying and expressing affect and communication. And it's delivered in 12 to 15 weekly sessions, generally over a 3 to 4 month period. So the process, developing a depression story, centres on collaboratively developing a way of understanding and resolving the current episode of depression in its interpersonal context. So during the first 4 weeks, the assessment phase, relationships were explored in detail and their links to the current depressive episode analysed. The theme is identified and agreed, and during the remaining 8 to 11 sessions, progress towards the goals have been identified and monitored. The evidence base for IPT-A, it's been evaluated in 7 matched trials and RCTs. It's demonstrated equivalent or superior treatment outcomes when compared with other treatments. Delivered in health and school settings, delivered in different cultural settings. 50 to 82% of adolescents met recovery criteria for depression across the reported studies, and there's been specific superior effects noted for self-esteem and social function. Competency-based training. A competency map for IPT-A was developed within the overarching IPT competency map, and this has served as the basis for the curriculum that we use to train IPT-A therapists. You can see it there. And the IPT-A competency map highlights the central role of collaborative work and routine outcome monitoring in IPT-A practice, which makes it highly compatible with the core service transformation principles at the heart of children and young people's IAPT. Increasing equitable access. So despite it being an evidence-based therapy, it remains very difficult to access for young people with depression because the number of practitioners and supervisors remains extremely small. The CYP IAPT programme will more than triple the number of IPT-A supervisors in the first year and generate an equivalent increase in the number of therapists accessing practitioner training and accreditation level supervision. So in summary, it's a time-limited, evidence-based treatment for depression in young people. It targets the key areas that trouble many young people, and it monitors symptom reduction and progress on a weekly basis, and it's been shown to achieve outcomes that are equivalent or superior to existing